and pray with me, and all my blessings is gone out the door. She was with the last one. Well, I got one more left. I guess you're right. I'm gonna have to start. Uh, uh, I start have to be the prayer warrior now.
Yep.
Yeah. So let's. So I'm going to talk about this. So while we're here, let's just everything right. Yes, we're on. So we'll be right back on 30 seconds, and we're ready to stroke it. Yes, welcome to now it's called Podcast Live. Before I introduce our guest, we want to kind of talk about a little bit what's going on here at the community. We call it our PSA. We do this free for those in the community. The first, let me go and post this up right quick. And that would be the first annual scholarship golf tournament. That's going to be Saturday, April 9th. And the, I guess, is with the, I got one more left right quick. And that would be the first. I'm hearing an echo. Okay, I'm
Yeah.
back. Yeah, I don't know where that came from. So anyway, the at the Hamburg golf course, and it's sponsored right there on Babes and Harris Drive, and it's sponsored by the who sponsored this?
100 black men.
100 Black Men. Great, great.
Mhm.
The pre-registration before March 19th, that was yesterday, was 65 per person per team, and six to 260 bucks per team. And register after March 19th is per person $75 and $300 per team. Let's get involved, people, and help our local uh, community, those who works in the background, helping us in the community. Now, the Democratic Convention was Saturdays. I missed that, so we don't have to talk about that. Uh, on Friday, next Saturday, the 100 plus Black Women Coalition of Beaumont, the 16th annual Black, Red, and Green banquet would be at 7 o'clock at the MCM Elegante Hotel right here in Beaumont. It's a semi-formal coat and tie, where black, red, or green if possible. With that, let's get that out the way, and so let me introduce you to our guest. And our guest tonight is going to be Mrs. Kimberly Parks. Kimberly is the RN at Hospice Harbor Harbor Hospice. Okay, and she's going to be joining us because we're going to talk about a subject that I not aware of or not unaware of, but I have questions about it. I always want to know about hospice. I didn't know what hospice. All I knew that's where you go to die at hospice. But now that I found out, it's much different and than what I always thought it was. So this is why we want to bring Miss Kimberly on today. So we need to know how to handle our elderly. That's not just elderly; those who need hospice. Uh, I mean, I need to know how to prepare because my parents are older now, and I know they're in the fourth quarter, and I need to know what to do with them and how it's done. So let's bring on. Before that, oh, wait a minute, Kim. I'm sorry. My co-host Francis Larkin, Trisha Primo, and Terry Roy. Terry Roy is going
Hi.
to be Terry Roy is going to be the lead host tonight. So
All right.
I'm going to turn it over to
Hello,
Mr.
everybody.
Perry
Hello.
Roy.
Hello. Welcome, everybody. Thank you, Tony, for letting us use this platform to get out the information, the misconceptions, and the truth about hospice. And I'm glad Kim was able to come on tonight because she's a very busy person. So
Thanks, friend, for the invite.
Yeah.
I'd like for her to come on and just, and tell everybody what hospice really is, what they really do, what she does, and how everybody can be prepared. So, Kim,
Yes.
it's on you.
It's on you,
Okay.
Kim. Let me put you on the centerfold here. There we go, Kim. There we go.
Hi, nice meeting everyone.
Hi, Miss Hi. Kim.
Thanks for having me. So I've been doing hospice for 15 years now, and I have heard many stories about hospice. When families hear the word hospice, they say, "Oh, that's where they go to die," or "That's where y'all go give them morphine and put them to sleep." But no, that is not the case. So I just kind of highlighted a few things to tell you all about hospice so that you can be more aware of what hospice is, what it's used for, what our purpose is, and, just go from there so you can have a better insight of what hospice is and what we do. So what is hospice? Hospice is very unique. Not everyone can do hospice. It's designed to provide comfort and support to the patients and to their families when their illness no longer responds to treatment. So what that means, and I explain this to families all the time, you send your loved one to the hospital so the doctor can do everything that they possibly can for your loved ones. Once they get to that point to where they can't do anything no more, they're just pretty much putting a Band-Aid on your symptoms. That's when they pretty much refer you to hospice. So with that being said, you have a terminal diagnosis of 6 months or less to live. So not everyone qualifies for hospice. Some people think, oh, I'm old, I'm about to die, so put me on hospice. But you have to have a terminal diagnosis that support that need for hospice care. So once that patient is diagnosed with a terminal illness of 6 months or less, that of course it impacts the whole family. So not just the patient, the family then, think about, oh, what are we going to do from here? The doctor says nothing else that can be done. So what can I do to take care of my mom, take care of my dad, or, to help them live a longer life? Of course, we all are here to die. Some people hate to hear that, but we're all going to die someday. So that's when we step in, so we can provide spiritual support, emotional support, physical support, and it allows the patient to die in peace and comfort. And, they can die at home or wherever they choose to reside in a nursing home. And the real good perk about Harbor Hospice is we have a inpatient facility. So that pretty much takes the precedence over every hospice company that you can think of. That way you can come in and you can get taken care of inpatient and die inpatient, because some families don't want their loved ones to die at home. They can't live in a house once someone dies. So sometimes, that is that extra place, that special place that they can come to and still be surrounded by their loved ones. So our hospice team, we're available 24 hours, 7 days a week, and it consists of a physician, a nurse, you have an aide, a CNA, what most people are called, social workers, spiritual counselors, and we also have volunteers. So the physician's role is to pretty much just see the overall care of the patient. They write out a plan of care. A patient may come in for pain, so they'll put a regimen in place to control that pain. And of course, so the nurse will carry out that duty as far as giving the patient what they need to help relieve that pain, or if they're having nausea or shortness of breath, we treat, those types of symptoms. And of course, the aid is to make sure, they're getting taken care of, being fed, getting bathed, grooming. If they're in our facility, if they're at home, they'll go out to the house and take care of that patient in the house. They don't sit there or stay, but they'll go out there and treat the patient as far as bathing, helping the families, educating them on how to take care of them when they are away from the house. Some of the focus of hospice, what our focus is of, caring. We're caring for the patient, not curing the patient. Because a lot of times when they're inpatient, the families get asked, hey, can y'all give blood? Can y'all do surgery? They ask all types of questions that you can never imagine. And but no, we just tell them we're just here to provide relief from their symptoms. We're also there to support the families and to provide the patient with dignity and respect, while they're suffering through their symptoms. The goal of care is to improve the quality of the patient's last days by offering comfort and dignity. So some of the criteria, like I said, everyone does not qualify for hospice. It's not for everyone. Like I said, you have to have that terminal diagnosis of 6 months or less to live. And then you're also desiring hospice care, and you're no longer wanting to seek aggressive treatment. So let's say you're a cancer patient, or you have a family that's had cancer and they're getting chemo and radiation. We do not provide any of those things. So once, we do encourage, if that's what you want, by all means, go, get that chemo, go get your radiation. And then once you feel like you're at the end to where it's not doing anything to help you anymore, that's when you come to us. And then we, take over and provide the symptoms, the residue that the chemo and the radiation left. Or like your COPD, the shortness of breath is what we control. Just, various symptoms that you may experience, and it's uncontrollable. You come inpatient to get treatment. And then you don't have to come inpatient. Some families and patients, they rather go home to a familiar environment to where, they're comfortable there. They can lay on their own bed. They can have whoever they want, surrounded by them. And, the nurse will go out to the house, but they go out once a week. You have the aides go out there at least 5 times a week. You have a spiritual counselor go out there once a month. And then the social worker also will visit and check on you once a month as well. Just make sure all your needs are being met, making sure you're not in a crisis is what we call those symptom management. And then we also have different levels of care. So those different levels of care includes like routine home care. That's when you're at home. Those are the most common admissions that we do get. And then we also have the general inpatient, and that's when you come into the building, the facility, because you have a crisis that needs to be managed with IV medications, breathing treatments, or trach care, G-tube management. We do it all. And then also, if you're too sick to be sent home or too sick to come to our inpatient facility, we do manage your care in the hospital. And then we also have a respite care. That's another part of being on hospice, is that, the caregiver is the primary, the family member. You choose a family member who is a primary caregiver for that patient. And sometimes they have to go out of town, or sometimes they just need a break. They're overwhelmed, they're tired. So they'll send them in to our inpatient unit. We do like 5 days a month. Just to give the caregiver a break. So we call that pretty much like a caregiver breakdown. So not only are we there for the patient, we're also there for the family as well, to kind of relieve them, encourage them, educate them, and just kind of relieve some of their burdens as well, because they do still have families to take care of as well. So pretty much how hospice work, just to sum up everything, typically, like I said, the family member is the primary caregiver. And then when it's appropriate for that patient to switch over, transition to hospice, we help them make that decision, hey, your family is approved to come onto hospice services. And then we just pretty much sit down with the family, go over what we provide, and the services that's rendered, and we just go from there. Then they choose if they want our service, or if they don't want hospice at all, or if they want other services. We don't persuade them either way. We just give them their options, and we just go from there.
Okay. All right. Just like you, I've been doing it for a minute. And how do you, when you go home, how do you get that off of your mind? And like some of your coworkers, what are some of the things that they do to get it away from them?
Well, and that is a good question, because even, myself, sometimes I deal with, the struggle of just, sometimes we just get attached to the patients. We think about them throughout the day, throughout the week, just sometimes, they're suffering, and, we've done our best to try to alleviate some of their pain and nausea, vomiting. But it gets hard sometimes. So we just kind of de-stress. The off time does help when they're able to take their days off, their vacations. We do encourage them to take vacations. Sometimes in the facility, we do have like one of our spiritual counselors will come and do like the blessing of the hands, kind of like a thing where you just come and give us a little soft lotion and pray for our hands, like a hand of healing, pretty much.
Yeah, I think we need that where I'm at too. So
yes,
because we go into the different homes and it's some stuff you don't, I'm gonna have to look into that.
Yes.
You may tell them to come and see us too. So
right. And overall, I just believe in taking vacations.
So I'm sorry, what is available for families who have somebody in hospice and it's not going the way that you're describing? Are there people that can be reached out to help with that? Or
yes, we get our spiritual counselor involved because they are really good. We have a great team for spiritual counselors. And a lot of them have also been doing it for a long time. So they just have that wording. They'll pray, read a scripture. And then also we have like volunteers. They'll come and just kind of, give them words of encouragement and just let them know that they're there for them. They offer emotional support as well. Just sitting there listening to them talk, just getting off, just talking about their burdens that they may have or their difficulties they may have, because like I said, they do also have other families that they have to take care of and then worry about their sick loved one as well.
What about families who have a hospice care facility that's not doing what you explained, that isn't providing the things that are needed like you've described?
But you're talking about the other hospice services,
yes.
Other hospice
Is
companies?
there somebody that can be reached out to when that happens, if it happens?
Yes. Now, some other companies, they do have, which one thing I didn't mention, I failed to mention, was the continuous care. So we do have some companies, which we've done it before in the past. You can go sit out at the house with the families, with the patient. But it's not around the clock. It's maybe 8 hours in a 24-hour period. Some are contracted with nursing facilities where they can send their loved ones to that nursing facility and have a nurse there to take care of that patient. Yeah. But with our facility, with the inpatient unit, like I also explained to the families, instead of going to the emergency room, they come to us, and because we're pretty much like a crisis center. And then we have a physician that's either on site or can be reached by phone to get care started right away. I'm not sure if I answered your question.
I don't want to go too deep into it, but I was recently, a friend of mine was on hospice, and it wasn't as you're describing.
Okay.
The company that they had coming in wasn't taken care of like you've explained. So if that should happen to somebody, is there somebody they can reach out to get help with that?
So what some of the families will do, they'll just call that hospice service and that they're with and tell them that they don't want their service anymore, or they can reach out to us and say, hey, I'm on this service now, I want to come on to Harbor Hospice. What can I do? And we have a clinical liaison reach out to them right away. We've also had some that just, because their symptoms were so bad in the home, they went to the hospital, and then from there they seeked our services through us. Okay. And we just pretty much, they're just a phone call away. You just call that number, call hospice and say, hey, I want hospice for my mom, for my dad, for my family member, and we jump right on it. Our process is a 2-hour window process. And that's pretty much how long it takes from the start of a referral to looking at getting records requested, looking at the records, and deciding if that patient is appropriate for hospice, and then either admitting them home with our hospice care or inpatient with our hospice care.
Okay.
Now, Tricia, like you, I had a similar experience. Now, my grandmother transitioned in October, and right before her transition, maybe September, she was placed in hospice. Mm-hmm. Now, from what was, I guess, described to her caretaker about hospice was not delivered.
Right.
A lot of those services, because I actually tried to convince her caretaker to, hey, put them in hospice, because they don't just, give them morphine, put them to sleep and make them, comfortable right before passing. There are other services that are offered, for some type of quality of life before. But where our disappointment came in is that while she was on hospice, she was suffering from some stomach issues, some stomach pains. And as a family, we just felt that she wasn't given the proper treatment. It was
Right.
as if, like, we're promising you these things, but they didn't deliver. So, when they came out and they gave her the, I hate to say, spill on hospice in their program and selling their business, it wasn't really described. As far as her medication goes, they were all wrong, they were all incorrect. And during those times, it's like, okay, this, we're just trying to get our minds right, because now we've put our loved one on hospice. So we understand that there's more services, but ideally your mind is that this is their last phase, as Tony mentioned earlier, their fourth quarter. So
it's also hard because the hospice care that came out to the house for him, they wrote the prescription, but they did not administer the meds. So I'm watching as his children are having to give him his final meds, and he's begging for more. He's in pain. It was horrific. And they didn't come out until an hour and a half after he passed away.
Right. And so our experiences may not have been as good as we had hoped for, So how do, those problems be corrected from the person that goes out and sells the services of the hospice company to that caretaker, to make them really understand? Because yes, there was supposed to be someone that came out. Yes, there was supposed to be that person that, that kind of like assisted even the caretaker, but it wasn't delivered. How can we alleviate that from, moving forward? If we do have another loved one, how can we trust hospice again to deliver those things?
Okay, so once they sign on to service, let's say they do go home. Once they get home, they are to call and let our hospice know that, hey, my family is home. We're ready for admission. So then the nurse will go out to the home. They assess the patient. They will meet with the family, educate the family on what we provide, what options we have available when needed, and then also go over the medications and how to administer the medicine. So, since you are at home, since that patient is at home, the family will be the one to administer that medicine. But of course, it's up to the nurses to go over the medicine, have it written down on paper in black and white. This is how to administer the medicine. This is when to administer the medicine. And then if it's not working, call me and I can troubleshoot you over the phone. And if that's not working, then that's why we have the inpatient facility. We'll send you in patient and then let the nurse, a professional team help take over from there.
So Kimberly, what you're saying is send all of our loved ones to Harbor Hospice, because you guys are going to do and deliver what you said you're going to do and deliver.
Yes, ma'am.
Absolutely. I love it.
Yes.
I just want to say, hey, Kim.
Hi, Chris. How are you?
Awesome classmate. Good to see you.
Good to see you.
Yes,
okay.
Indeed.
What are some of the questions that a family should ask hospice when they're getting ready to admit them? Some of the main questions.
So, and our families sometimes do ask a lot of questions, and
yes, they do.
And they should, because the ones that don't, they are, okay, let me just back up. They ask all the questions, and sometimes they don't hear everything because it's just so much and it's overwhelming. So we always tell them, hey, ask that question again, write it down. But some of the questions that they should ask is, the nurse, when they get admitted, if they're going home, when will the nurse be out here? How often will the nurse be out here? And how often can I call the nurse? So we're available 24 hours, 7 days a week. So no matter what time of the day or night, call us. We'll be available. And then also the type of services that we provide. So we do provide, pretty much crisis management, symptom relief. We do have restorative care. I forgot to mention that because a lot of families do ask about physical therapy. It's not that aggressive physical therapy, but it's just to kind of help maintain where their baseline is. If they can get up and sit in a chair, we want to continue that. So instead of just laying down in a bed all day and and all night, 24 hours, we do try to promote your optimal level of care of where you were or where you're at, from the time you get admitted to the hospital until the time you come on to the hospice service. You have a physician, you want to ask how often can you see the physician. I'm not sure how often they make home visits, but inpatient, I know you'll see the doctor every day, Monday through Friday, and then a nurse practitioner on the weekend. You want to ask about medications as far as their medications that they were on before they got on hospice service, because sometimes they do not ask those questions. And the doctor, of course, we're all about comfort. So we're going to do comfort medications. And then 5 days later, they'll say, oh, hey, my grandmother was on blood pressure medicine. I want her to continue that. So it's just standing in communication is the number one key, just communication about everything that you can possibly think of, questions you can possibly think of. Just make sure you're asking those questions, being involved. I always try to encourage my team to keep the families involved, call them, let them know what's going on with their family member. If there's any new orders, let them know. If there's any changes in the patient status, call the family, let them know, because sometimes they're not aware that, they're at that very end. Because we do have some patients that go home, they go home, they go to the nursing home. They don't just stay inpatient. That's another question that needs to be answered. I
was going to ask that question.
Wait, before you ask that question, I'm going to go to the comment board, and I think that question is right here. Someone wants to know, in the healthcare field, I have seen where families have initiated hospice, then decide later that they don't want it anymore. What reasons could they be removed from hospice?
If they just don't want it anymore, and that's the reason in itself. I don't want hospice no more. I want to do this on my own. I want to do this my way, or I want to go back to the hospital and seek aggressive treatment. And then by all means, we let them, do whatever they feel they need to do for their loved one. And then we just encourage them that, hey, once you've exhausted all your possibilities, you are welcome to come back to our services. Because sometimes families just feel like, they want to feel like they've done everything that they possibly can before they sign up for hospice. Some leave and go to other companies just because they either know somebody, and sometimes, they just feels like they can get better services from, somewhere else. But I always say, when you leave, you coming back.
So
that's a
Kim,
fact.
I guess my question is like, once a patient goes into, I guess, hospice care, do they ever come out of hospice care? I mean, like is it I heard you say you do wound care and a lot of different services that Harbor Hospice offers, and I know about Harbor Hospice. I will say the team, the new team, is phenomenal. It took some getting some tweaks out, but y'all are phenomenal, and I definitely adore people that not only take care of older people, but take care of people at that particular time in their lives.
Yes.
And it's very complicated, but I just wanted to know how often, because Francis mentioned, when we hear hospice, that's the end of it,
Mm-hmm.
and get ready, start preparing for the end or whatnot.
Yeah, that's what I thought. Mm-hmm.
But is that the case in every instance, or with the services that y'all offer, do y'all, release patients back into their home to, live a little bit more productive life, I guess?
Yes, because we have had some patients that signed up for hospice, and they've been on there for a year or even longer. And we say, okay, you're not there yet, so we're going to discharge you off of our service because you still have more life to live.
Awesome.
Yeah, we have done that several times, and then some we discharge some just because they're not appropriate. Because we do have, believe it or not, we do have some patients that pretty much look at us as their last option for pain management. Pretty much, they like to use us for pain management, and so we have to tell them that this is not what we're here for. We're here for your last, 6 months or less years, months on Earth. Sorry. We have some young patients as well. The youngest, we have PD patients we've had on hospice. We have 2 on hospice now. So, we take them we just had a baby, was like a few days old that we took, and she passed maybe not even a week on our service. So we take them from the very young to the very old. I've also had some experience with at least 2 of my family members. They were very much hospice appropriate, but they weren't ready for hospice. One had cancer. Well, both of them had cancer, and they still wanted to seek that aggressive treatment. And because, my family member was young, he was in his 30s, and his parents were like, no, I'm not giving up. I'm not, I'm not doing it. I'm taking him to MD Anderson. I'm taking him to
Cancer Center of America.
Yes. Yeah. And they did all of that to the very end. And as much as I want to say he need hospice, let us take care of him, they did not want to hear that. So, you just have to give the families that choice to decide which route they want to take as well.
Absolutely.
Okay. Another question people always ask is about how do they pay for hospice? Is that something you can maybe give somebody some information on?
Yeah, so a lot of our patients have Medicare. So we do take it's Medicare. We do take patients with Medicaid, private insurance, and sometimes we do take charity patients. They don't have any source of income at all, just to kind of help the family out sometimes.
Oh, that's awesome. And you said private insurance. Now, is that a clause in most private insurances that you have to have, I guess, like hospice care coverage or something?
The most, the issue that comes with the insurance is placement issues. So, as far as, once they come inpatient and let's say they stabilize and they can go home to a home setting, or to a nursing home, that's usually when our insurance does become a problem, because nursing home only takes Medicaid patients. So, and then of course we get all the Medicare patients, and then their family can't take care of them in the home. So then we pretty much get not really stuck with them, but they end up staying with us for a longer period of time, because there's no one to take care of them at home, and financially they're not able to go to a nursing home.
Yeah. Okay.
Now, our facility is not a long-term facility. That's another thing that get misconstrued. A lot of families, send their family there like, yeah, we want hospice. They come to us, and then they'll say, oh, then we start discharge planning and say, oh no, I thought they was going to stay there forever. I thought they was going to stay there till they die. And, so we are a short term just to get their symptoms under control. And then we do start looking at discharge planning if they're, leaning towards that route. A lot of families ask us how many days. It's a day-by-day case, depending on the patient. But usually it's been shortened because of the Medicare guidelines. They like to have you there no longer than 7 days. But of course, if you're still in a crisis, we can't say, okay, you got to go, because we're still treating that crisis. But there's just some things to think about as well. What about other options once they come to hospice, if they're not at that point to where they are at that very end of life?
Awesome.
That is awesome. Anyone else want to ask a question?
I want to ask, even after the patient passes, what all does Harbor do after the patient passes?
So after the patient passed, we do have a bereavement team. They will be reaching out to the families for 13 months after the patient passed. They'll do phone calls. They'll do visits. We've even had some of our spiritual counselor get asked to do their funeral services. So they're there for any type of bereavement that the families may need for the next 13 months after that.
I think that's especially with the bereavement support. I think that's phenomenal because most even facilities like nursing homes after they pass, you probably get a flower at the repast or something like that. Showed the facility, but like as far as like you said 13 months of bereavement care, you know what I'm saying? And that's for the family, and we all mourn differently and bereave in different types of ways. So I think that by itself for the families is a step up, because again, it may be it may be a little harder for me to deal with, auntie than it was with grandma or something like that. You know what I'm saying? Right. So I think that's phenomenal that y'all do that. Yes. Harbor Hospice offers that care.
Yes, they stay in touch, and they get attached to them sometimes too, to where they want to know how they're doing after the fact, and just sometimes they just call and talk to them, just have a conversation. I had to call several families, and they just sat there and just wanted to express and explain and talk about the memories that they had, and I just sat there and listened to them. That's all they wanted.
Yep, that's all they need.
Just to,
yep.
I'm glad that we invited you. It means so much to not just for me, for everyone. We have loved ones, family members that we care for and care about, and we get to a point where we kind of at that moment you can't think what to do next, but you want the best care for your family member or loved one. And I wanted to know what was the steps. What should I do? Because not only me is going to go through this, but there's going to be everyone is going to go through it.
Yes.
And as time come by, and also, would you also tell me it doesn't have to be an elderly person to be in a hospice, right? Right.
It can be from birth on till we have from birth till the oldest we've had was 104. And the youngest we've had was a few days old. Yes.
Wow.
Yep.
Wow, that's something. Now,
I too want to tell you, Kim, thanks for coming on the show, especially my stomping grounds. I definitely appreciate the information that you have given, because again, when we hear hospice, we only think that, like you said, that y'all gonna let them lay there and they're gonna wither away. And that's what, that's the mindset that we, a lot of us have collected.
Right.
When it comes to hospice. So again, I thank you for sharing that and enlightening me about it, because, like Tony said, we all have to make these plannings, and to be informed, to make these plannings is I know the sole purpose that Tony put this show together tonight.
Yeah, I wanted to make sure that we have, you get an understanding on preparation.
Yes.
That's the part, preparing for it. And don't wait till they get to that age or that time. Start preparing just like you're preparing for a funeral. But that's prepare what to do next. My mother, back about several months ago, developed dementia, and she accidentally fell and broke her hip. And but her mind was still right, and we put her in the hospital, and she had to have surgery. From surgery, I moved her from surgery to therapy, rehab, because I knew if I had brought her home right after the hospital stay and surgery, she would never walk again. So we put it in a therapy, and today's therapist coming in 3 days a week, and she's at that fragile age, and her body is fragile, and we're at that point. So okay, now she still have a right mind. You do, even though she has dementia and it's increasing. You know, I want to know what to do, how to prepare myself when that time comes, because I know that time is coming.
Right.
And you have answered some of the questions that I had in mind. And I thank you, Terry, also for inviting Kimberly Parks to our podcast.
Yeah,
because
Jaguar.
Jaguar, such a Jaguar. But not only me, but all of us need to know how to prepare for our loved ones.
Right.
Yeah. I think the most crucial part on hospice is the part that I like the most is the respite care that they offer.
Yes.
Because you wouldn't believe the toll it takes on families when they're trying to keep somebody at home.
Yes.
And when you can get somebody to come in and take your family member and give them great care, because, you know, not only because I'm affiliated with Harbor, but, you know, they're the best.
Right.
Yeah.
You know, that's a fact. But the respite care, it's, you know, it
Well,
helps.
Can I ask what areas do you all cover? How far out do your services reach?
It's pretty much like in the Bowman area, we go the 60-mile radius is our zone, but we also have office in Jasper. We have one in Houston, in Baytown, in Austin, Chicago, Vegas. I mean, we're scattered everywhere.
Yes, you are. Yeah.
So every location offers all the same services.
Yes.
Okay.
So no matter where you reside, you can call Harbor Hospice and we will get you placed whatever's closest. But in Bowman area, we're 60-mile out radius, but then we have the Jasper location that'll pick up, catch those other surrounding areas.
Well, I think that's going to wrap it up, Terry and Kimberly. We thank you so much for answering.
I appreciate you, Kim.
Yeah, giving us some
Thanks for inviting me.
Important information, girl. Oh, I needed that. Yeah, I read a lot. I'm what they call an avid reader.
Avid reader.
Yeah, I read all night, all day long, and I don't know everything. Okay, and I that was something that I need to know. What and how to prepare for it if it happens to come to that. To it, not just me, but anybody. Right. That's very informative. Thank you so much.
Thank you for having me.
And thank you, Terry.
Oh man, I'm glad.
Francis and Chris.
Good to be here.
I apologize, y'all, for being late. I just got off the highway, by the way.
Oh, well, we understand.
Glad you're back, Chris.
Glad you're back, son. Back. Hey, on I need to let you know on let's see, I think Tuesday our podcast will be LaDonna Sherwood, which is our co-host. She's going to be with Bobby Patterson with the 100 Plus Black Women Coalition, Beaumont Inc. They're going to be with us on Tuesday at 7 on Now This Is Power Podcast Live. So with that said, I've got one more comment. Let's see what the comments. The comments are telling. All the comments are telling. Thank you for everything. Big shout out to Brenda Blood Foster's. She's saying thanks, Kim. We all need this information, you know. So not just the elderly, you might be your sister, your brother, your nephew. We need to know. Thank you so much, Kim. I enjoyed the show, and we'll see you guys back on Tuesday at 7:00 on Knowledge is Power podcast.
Thank you for watching Knowledge is Power Podcast Live. Be sure to like and subscribe to all Knowledge is Power social media pages.